فراس.
السلام عليكم.
السلام ورحمة الله. You can start.
Okay. So Faraz Fatani, R1 at University Hospital in King Abdulaziz, Jeddah. I'll be presenting anatomy of cardiac chambers, conduction system, and nerves. My tutor is Prof. Khalid Al Ibrahim, head of cardiac surgery at University Hospital.
فراس، ما ادري الصوت عندي بس ولا عند الكل؟ صوتك مره ضعيف.
صوت ضعيف كذا احسن؟
الان كويس، الان كويس.
ايوه طيب الجولز حقت الليكتشر اللي to identify morphological characteristics of cardiac chambers and to identify conduction system of the heart, also to identify adjacent nerve that might be injured or should be taking good care of not to injure during cardiac surgery. So starting with surface anatomy, the heart is a muscular organ that pumps blood throughout the heart. It is composed of 4 chambers: right atrium, the right upper chamber, right ventricle, right lower chamber, the left atrium situated at the back behind the aorta, left ventricle, the left lower chamber. Right and left ventricle are separated by interventricular groove. So starting with the right atrium, the right upper chamber of the heart. So the right atrium receives blood venous drainage from the superior and inferior vena cava and coronary sinus. Inferior vena cava and coronary sinus. The right atrium is surrounded by structures, the vena cavas, the aortic sinus, and the left atrium. The anterior wall of the right atrium is located close to the right coronary cusp of the aortic valve. So there are morphological characteristics of right atrium that helps identify it and to differentiate it from the left atrium. So first and the most indicative morphological characteristic is a wide-based and blunt-ended right-sided appendage. And the picture in the next slide. The presence of limbus of fossa ovalis. So this is the fossa ovalis, and the thick surrounding is the limbus of fossa ovalis. Valves of inferior vena cava and coronary sinus, eustachian valve, antibasian valve. You can see the mouse, right?
Yes.
Also crista terminalis, where tuberculated, the rough surface of the right atrium is separated from the smooth surface. So the right atrium can be divided into the body, which is the auricula. It is rough surface and include the right atrial appendage and lateral free wall of the muscle bundles that give it the tuberculation. The sinus part where venous drainage happen or take place. Also called sinus venerum. The borderline between the smooth and rough surface of the right atrium is called crista terminalis, where the rough surface terminates to the smooth surface. It has its importance. So in this crista terminalis, starting from the anterior to the superior vena cava orifice, running downward till the IVC, station valve, and Thebesian valve, till the Tudor tendon. It contains the internodal tract, runs here. Also, the crista terminalis contains the orifice of the vena cava and coronary sinus. So the atrial septum is fossa ovalis and the tissue surrounding it. There is also the atrioventricular septum between atrial septum and septal leaflet of tricuspid valve here. It separates the right atrium from the left ventricle of the heart. There is also an important landmark in the right atrium, also called Triangle of Koch. It has a border here and the coronary sinus, Tudor tendon, septal leaflet of the tricuspid valve. In this triangle, there is the AV node. Also, there are the surgical incision in right atrium is made for surgical procedures of tricuspid valve, ASD, VSD, tetralogy and others. So also a good exposure of mitral valve can be done through right atrium, either by penetrating the septum or cutting from the septum till the roof. Also during the procedure, as I've said before, the triangle of landmark triangle of Koch and the superior vena cava anterior to superior area close to the superior vena cava should be taken care of. Superior vena cava, the area surrounding it runs the sinoatrial node, SA node. So moving to the left atrium, left chamber of the heart. It lies behind the ascending aorta and is superior to the left ventricle. The left atrium can be demarcated from the left ventricle by the atrioventricular groove. The structures in the left atrium, you can appreciate the 4 pulmonary veins, left and right. Here also. The left atrial appendage. The right and left trigones. The right trigone where bundle of Hess is located. The left trigone is where during mitral valve procedure the aorta is more susceptible in this area, in this trigone. Also septum primum. So morphological feature for the left atrium is left atrial appendage. It is long and narrow, and there is no cresta terminalis. The only tuberculated surface or rough surface in the left atrium is the left atrial appendage, and there is no termination to the smooth surface. There is no cresta terminalis. Surgical characteristic of left atrium. The left atrium, as seen from the picture before, is deep and difficult to expose. It is immobile. Space for incision is limited. Left atrial wall is thin and liable to tension injury. So there are surgical route to left atrium. Right interatrial groove, interatrial septum, roof of left atrium, or left ventriculotomy reversely. Right ventricle right lower chamber of the heart is thin-walled and compliant and can only sustain the low pressure of pulmonary circulation. The right ventricle has three portions. The inlet portion, also called sinus portion here. The outlet portion, infundibulum, and the apex. The right ventricle, the infundibulum of right ventricle is located between the pulmonary valve and the supraventricular crest. It consists of septum and membranous septum and include variety of muscle bundles, septal, parietal, and moderator band, parietal, septal, and moderator band. And through moderator band runs an important structure, will be clarified later. The membranous septum, a small septum, very small, but has its significance. This is the membranous septum, and this is an illustration of it and the structures near it. So above it is tricuspid ring and atrial part of membranous septum. Lower to it is muscle of ventricular septal crest. In front is the infundibular muscle. Its upper portion is composed of septal valve. So this is the membranous septum. This is the tricuspid annulus and the crest of the tricuspid valve, illustrated here. It is divided to two parts. Here, the membranous septum of left ventricular right atria, and the membranous ventricular septum here. Near it is the AV node, and here is the illustrated here, the non-coronary cusp of the aorta and the right coronary cusp. You can remember it by no, you have no right to be here. No, the non-coronary cusp and the right coronary cusp. The right ventricle, the anterior right ventricular wall can be divided into three portions. Here, the conus, sinus, and tubercular muscle. This is the conus, this is the sinus, and this is the tubercular muscle. The anterior wall of the right ventricle is easily exposed, but anterior approach should be with care not to injure anterior papillary muscle and moderator band. The moderator band where runs the right bundle branch. The principle is to avoid the important branches of coronary artery and tricuspid anterior papillary muscle when you doing operations to the right ventricle. So in this, the area where in the conus is the area where which is that can be done for ventriculoplasty. Here runs the moderator band, the tubercular muscle portion, tubercular portion. So the left ventricular wall is mortar in shape and is formed by a thick twisted myocardial bands that anchor to the cardiac fibrous skeleton at the upper end. It is divided into three portions: interventricular septum, diaphragmatic side of the left ventricular wall, free ventricular wall in the left atrium, in the left anterior. So the avascular part behind the interventricular sulcus, the conus, is the preferable site to perform ventriculoplasty in cases of dilated in case of dilated left ventricle. Here. So the left ventricle, the cavity of left ventricle is divided to sinus portion, trabeculated portion, and outlet portion. This is the sinus. This is the tuberculated portion, and this is the outlet portion. The outlet portion, left ventricular outlet tract, has an anterior wall, the ventricular interventricular septum, and posterior wall, the anterior mitral leaflet. So in hypertrophic obstruction of left ventricular outlet tract, where some of the muscular portion is excised, an accidental piercing of ventricular septum can cause injury to AV node or mitral valve papillary muscles. Also, left ventricular outlet obstruction during a mitral valve replacement in an obstruction of left ventricular outlet tract, a mitral valve replacement can eliminate the anterior movement of the anterior mitral leaflet during systole and exacerbate the already obstructed left ventricular outlet tract. So this anterior leaflet of the mitral valve is moved anteriorly to open the passage for blood. If during mitral valve, if there is mitral valve replacement and left ventricular outlet tract obstruction, this might cause or exacerbate the obstruction. Moving to the other.
Again, please.
So the left ventricular outlet tract here, where it terminates to the aorta, it has two walls: the atrial leaflet of mitral valve and the interventricular septum. So it moves, the blood moves between atrial leaflet of mitral valve and the atrioventricular septum. So if there is obstruction, left ventricular outlet obstruction, the muscular portion here will be thick. And if there is mitral valve replacement, the valve that is replaced has less movement, anterior movement, to open the passage for blood to go outside if there is thickness in the left ventricular outlet tract.
So you solve it by valve replacement?
No, not valve replacement. If there is left ventricular outlet tract obstruction and just a mitral valve replacement, the patient needs a mitral valve replacement, and you put a replacement without solving the without doing anything to the obstruction, this might exacerbate it. So if the patient has an obstruction and you did mitral valve replacement, the obstruction will be more.
Okay, any other thought, audience?
No, I just...
Sorry for interruption. I'm with you. Any other thought from anyone in the floor, please?
Can I participate?
Yeah, for sure.
I think what I understand from you is that the anterior leaflet will, after mitral valve replacement, will be restricted, and the SAM would be worsened because the valve now cannot, the anterior leaflet cannot now go into the annulus. It's always obstructing the outflow tract because the new valve that was replaced.
Yeah, I think that this is the point.
Any other? From R4 and above. So you will have SAM after mitral valve replacement, and all audience agree about that.
I think if you don't remove the anterior leaflet before placing the valve, yes.
What is SAM?
Systolic anterior motion.
Okay.
Abdullah Al-Hidayb. Muhammad Babgi.
Yes.
What do you think? How are you, Muhammad?
Alhamdulillah. How are you?
What do you think?
I think it's less likely to have a SAM without septal hypertrophy and presence of a leaflet. If you preserve the anterior leaflet, probably you might have SAM, but if you remove the whole leaflet and replace the valve, you won't have a SAM. And unless there is a combined with hypertrophied septum, that will patient will be more prone to have a SAM. This is my thinking. I'm not sure if it's right or not. But what I understand from Firas is that putting a mechanical prosthesis in the mitral position, this will reduce the dynamic changes of the LVOT during systole. When the LVOT during systole getting a little bit expand, and having the natural valve, this will be more flexible to dilate and give space to the LVOT to expand. Putting a prosthetic mechanical valve, this will be not compliant as the normal tissue. So the LV diameter will be a little bit fixed.
So if you put a mechanical valve, you will have SAM?
I don't think so.
What is the treatment of SAM?
It depends, usually medical treatment.
Okay, after medical treatment. You are right, first medical, then?
Patient, if not responding to medical treatment, either you do septal myotomy or myectomy, I'm sorry, or you do valve repair, you resuspend the mitral valve.
Okay, don't say resuspend. Okay, myectomy for HOCM. Okay.
Yes.
So SAM usually came either in two cases, either in HOCM cases, okay, or exclusively after mitral repair, because of the height of the posterior leaflet, more than 1.5. Okay.
Exactly.
So when you do the management, let's take it if you did a repair and you have SAM after the repair, what the maneuver, surgical maneuver after medical, you will do. Sorry, I'm intentionally just discussing this issue because this is very important.
Yes.
Actually, the exact maneuver or surgical procedure you're gonna do for eliminating the SAM as a complication of post-mitral repair, I'm not aware about that. I think a little bit above my level.
Okay, so you just either you do, if you did initially triangular resection, you will do quadrangular resection with the folding blasty to decrease the height, to bring the cohabitation, because what happened, the cohabitation is pushed anteriorly, and this anterior mitral leaflet, it's pushed towards the LVOT, also because of the Venturi effect and because of the effect of the posterior long height of the posterior mitral leaflet, okay, that will push down and create more gradient. This is how the gradient created, or the MR created, because of the tether of the posterior mitral leaflet, and the Venturi effect pushed toward the LVOT, causing the SAM. So you need to bring the cohabitation line all together. What is the last option when you are faced with a SAM in the setting of mitral valve repair? You failed For example, you fail to do that. What the last things you have to do to eliminate the SAM?
I do replacement.
You do replacement. Thank you very much. So Dr. Faraz was saying that after replacement, we will have SAM if we have fixed septum. This is what
yeah, I don't agree with that.
You get the point.
Exactly.
Is anyone agree with that statement from the audience? So just think about it, huh? And
السلام عليكم.
عليكم السلام ورحمة
ورحمة الله.
أظن قصد فراس إنه إذا كان في LVOT obstruction we should deal with it before mitral valve replacement. If you do replacement with the thick LV, then you will get worsening the LVOT. I think that's what he meant, most probably.
Yes, doctor.
So if you have HOCM or LVOT obstruction with the mitral valve disease, you should deal with the myomectomy or before we deal with the mitral valve. I think this is what you meant, Firas?
Yes, I guess so.
Okay.
Okay. So I'll continue, moving to the next objective, the conduction system. So the conduction system is a collection of nodes and specialized conduction cells that initiate and coordinate contraction of heart muscle. And it consists of the SA node, internodal tract, SA node, internodal tract, AV node, common AV bundle, left and right branches of and Purkinje fibers. So starting with the SA node, it is located along the anterior lateral aspect of junction between the superior vena cava and the right atrial appendage, and extend medially across the crest of caval atrial junction. It sometimes extend to the crest of caval atrial junction. So it is superficial and pierced by sinus node artery. 50% of population, the sinus node artery comes from the right coronary artery, and in 45% from the left circumflex. Its diameter is 1.5 centimeter. There is also the internodal tract between the SA node and the AV node. The internodal tract is composed of 3 channels that spread activation between those nodes: the anterior beam, middle beam, and posterior beam. The anterior beam descends anteriorly into the atrial septum near the fossa ovalis, then to the AV node. It also has a branch that is called Bachmann bundle that goes to the left atrium. Injury to those is associated with complete heart block or nodal arrhythmia. AV node lies directly on the right atrial side of central fibrous body, the right trigone, in the muscular portion of AV septum, anterior superior to the opening of coronary sinus. Sometimes its posterior margin lie against the coronary sinus ostium. It is flat, measuring around 0.5 centimeter in diameter, and it is supplied by the AV node artery from the right coronary artery. It lies in the triangle of Koch, a landmark that was discussed before. There is also the common AV bundle. The other name is bundle of Hess. A direct continuation of AV node passes to the posterior margin of the membranous ventricular septum. It is pushed backward in cases of membranous VSD and endocardial cushion defect, causing different degrees of conduction block. This is the same illustration as before, the non-coronary and right coronary, but it has the right bundle branch and left bundle branch. So the left and right bundle branch, the left bundle branch is when bundle of his courses along the posterior inferior border of membranous septum and crest of muscular ventricular septum, and gives fibers that form the left bundle branch. The right bundle originates in the region of anterior inferior margin of membranous septum and courses along the right ventricular septal surface. Moving to the last objective, adjacent nerves. There are important nerves that surrounds the heart, and damage to those nerves has a bad outcome. Feel phrenic nerves that supply the diaphragm, right and left. Damage to the right causes paralysis of left side of the diaphragm. Likewise for the left branch, damage to the or paralysis to the left diaphragm. So the left phrenic nerve descends on the left side close to the aortic arch and passes into the pericardium overlying the left atrial appendage and the left ventricle. It can take one of three courses. It might pass over the left lateral or obtuse margin of the left ventricle to overlie the marginal artery and vein, and it is in 66% of the population. Also, it passes over the neck or roof of the left atrial appendage in 20% of the cadavers or population. The right phrenic nerve descends vertically along the right brachiocephalic vein, and then along the right anterolateral surface of the superior vena cava to be related to the right aspect of right atrial wall. There is also left recurrent laryngeal nerve. Damage to left recurrent laryngeal nerve causes hoarseness and dysphagia. The branches of left vagus nerve descend to the left side of aortic arch and then passes beneath the aortic arch near the anterior ligament and ascends between the trachea and esophagus. This concludes my lecture. So those are my references. If you have any questions, feel free. Thank you for listening.
Thank you very much, Firas. Can I see the slide with the conduction?
Okay.
Yes, the one after. The one after this.
Next,
yes, I think this is the most important slide you should remember in the whole presentation, especially when you have VSD closure. Okay, you have to watch the tricuspid valve, the bundle, and to avoid injury. You know how to avoid injury in the VSD closure. It is, as Firas said, in the posterior inferior margin of the VSD. So you have to go below this margin with the sutures of the VSD and to be superficial so that you avoid injury to the bundle here and the heart block. And also you have to watch the aortic valve above you. So in VSD closure, you have to watch the aortic valve, the bundle, and the tricuspid valve. And you have to put the patch securely And keeping this slide in your mind all the time, you do a BSD closure as also between these two cusps of the aortic valve. And about the, how do you get injury to the phrenic nerve, Faraz?
I have no idea. If the
Maybe during pericardiotomy, or also before that, we can injure it by putting the ice while decreasing the metabolism of the heart. This is why,
Yes,
you know.
never by the rarely by pericardiectomy, of course, unless in redo surgery and this. But by ice is, of course, is a common mechanism. Ice is one. What other mechanism of injury to the phrenic nerve? Another also common mechanism. Why? Does anyone know?
When we do maze procedure, we can injure the phrenic also because it's near to the pulmonary veins.
Rarely, no. There's another more common mechanism of injury.
When dissecting the superior vena cava for the cannulation, for example, sometimes if you use a cautery, you might injure the phrenic nerve because it's coming close to the SVC at that site, I think.
This is another rare cause. There's another more common cause than this.
Harvesting lima.
Yes, yes, yes. You know, is the relation of the lima to the phrenic nerve?
Proximal. When you are
Yes.
going more in the proximal area, you need to be careful because it came more toward you.
Of course, in the first 2-3 centimeters of the lima is the phrenic nerve. So avoid in diathermy and dissection. This is the area where you injure the phrenic nerve. And of course, you have to avoid this. How would the patient usually present post-op Faraz if you have phrenic nerve injury?
ما يحضرني الحين.
Symptoms. What symptoms you will complain of?
Symptoms, signs.
Like you do cabbage and the patient come to the clinic post-op. What be the symptom? Dyspnea, of course, huh? Because of the elevation of the diaphragm, dyspnea. And how do you diagnose it? How do you diagnose
X-ray?
Just simply
Fluoroscopy.
Fluoroscopy. Exactly, fluoroscopy. Fluoroscopy is the diagnostic modality for phrenic nerve injury. And what is then the fate of this? What happens to those patients? If they have phrenic nerve injury, elevation of the diaphragm, what would you do?
Plication, but it's mostly conservative.
In adult, rarely you do plication surgical intervention. In adult, all cases, almost all cases respond conservatively by just, conservatory physiotherapy, chest physiotherapy and mobilization of the patient. Unlike in children, is almost you have to do plication to the in children and pediatrics. While in adults, most of the cases you respond to conservative. You know why in the pediatrics we do more plication than adults?
They are more dependent on the diaphragm as a muscle for respiration.
Exactly. The children, mainly 70-80%, they depend on the diaphragm. So once paralyzed, they will not come off the ventilator, they need plication. While in adults, most of them usually they occur with physiotherapy, usually 6 to 12 weeks. They will improve and diaphragm will come down to the normal position. طيب شكرا جزيلا فراس. شكرا.
الله يعطيك العافية دكتور. شكرا.
دكتور إبراهيم.
أي.
Dr. Ibrahim, can I ask a question? Yeah, what about when we are doing a double Riem and Lima harvesting and unfortunately patient got phrenic nerve injured and he coming with the both diaphragm dialysis. So the patient will be in the...
Of course, this will be a disaster. And the patient will be in the ventilator, will not be weaned off the ventilator. when you have bilateral phrenic nerve injury. It is usually maybe fatal even. You have to wait for some time. The patient will not leave the ICU with bilateral phrenic nerve paralysis. In this case, maybe you need, as you suggested earlier, maybe plication, and maybe this is the only indication for plication of the phrenic nerve, of the diaphragm.
The pacemaker may be an option for the...
And another pacemaker, maybe another diaphragm pacemaker, yes. But I never seen this bilateral phrenic nerve paralysis. Rarely it happens, but maybe in redo cases and maybe cabbage in redo cases, and if it is too much adhesions, you may get bilateral phrenic nerve paralysis. But this is, of course, a fatal complication, I must say. Another question? أي سؤال شيء؟
يعطيك العافية.
شكرا.
Thank you, Firas. Nice review in a simple way.
Okay, thank you very much, Firas, and thank you, Dr. Ibrahim, for the nice comments. So the next presentation will be presented by Dr. Mohanad Dawari. So I believe we can start at 1:50.
لؤي.
Yes.
ممكن نبدأ قبل عشان الكونفرنس.
كلها 3 دقائق على ما اجهز.
كم انت قلت؟
1:50.
اوكي I thought 2:15. اوكي سوري خلاص.
مهند
اهلا.
تفضل.
Assalamu alaikum wa rahmatullah. My name is Mohamed Dawari. I'm R2 resident in King Faisal Specialist Hospital and Research Center, Riyadh City. And today I will talk about the anatomy of coronary arteries, veins, and great vessels. In this presentation, we'll have overview about general structure of the vessels. Then we'll move to talk about coronary arteries, then coronary veins and great vessels, and we'll talk specifically about the aorta and pulmonary trunk. We will start with the general structure of the arteries and veins and the main differences between them. If we have a look to the cross-section of the arteries and veins, we will find that the tunica externa is looks same between them, but the main difference is in the tunica media, which is more and bigger in the arteries more than veins. And in regard of tunica media, tunica intima, it's folded in the arteries while straight on the veins. And if we look to the content of the wall of the arteries and veins, we will find that the collagen is more in the venous wall than the arterial wall, and elastic fiber is more in the arteries, and shear stress and stretch force is more in arterial wall more than venous wall. And one of the main characteristics of the arteries is the pulse, and some of venous wall has has valves while the artery doesn't. And if we compare the venous wall like with the lymphatic vessels, we will find that the main difference between them that the venous wall has more the lymphatics has more valves than venous wall. And this is the brief review about the general structure between the arteries and veins, and now we'll move to talk about the coronary arteries. We'll start talk about general about the origin of the coronary arteries. If we look to the aortic valve from the superior view, we can divide it to the non-coronary sinus, right coronary sinus, and left coronary sinus. And this naming is according to the origin of the coronary arteries. Like in left coronary sinus, this is the site of the origin of the left coronary arteries, while the right coronary sinus is the origin of the right coronary artery. And if we can divide it by angles, this sinuses from 0 to 120 degree is the right coronary sinus, and from 120 to 240 is the non-coronary sinus, and from 120 degree to 0 is the left coronary sinus. And usually the coronaries is originate in the middle of this angles. And if we look to the aortic valve from the lateral view, we can divide the wall of sinus of Valsalva to superior, middle, and inferior. The superior level is beyond the sinotubular junction, and the inferior third is include the base of the aortic root, while the middle is the part positioned between them. In case of coronary ostium is positioned in the superior third, we can describe it as high positioned ostium. If it is in the middle third, it's considered as normal, and if it is in the inferior third, we can call it as deep positioned ostium. This is this picture showing the lateral view of the aortic, the origin of the coronary, and if we can see in the left side picture, this is the right coronary sinus and the origin of the right coronary artery, and on the right side picture, the left coronary sinus and the origin of the left coronary artery. This is the origin of the coronaries. It's give two main branches, which is left main coronary artery and right coronary artery. We'll talk about the left main coronary artery as and its branches. Then we'll move to talk about the right coronary artery. The left main coronary artery is courses between pulmonary trunk and left arterial appendage, as we can see in this picture. This is the main stem of left coronary artery. It's up to 20 millimeter in length, but can be extended to 40 millimeter. And before it is the main two branches, which is circumflex and left anterior descending arteries. This picture showing the main stem of the left coronary artery, and we removed the pulmonary trunk to visualize the main stem, and before it is give its branches, and this is in regard of right coronary artery. Now I'll talk about the first branch of main stem of left coronary artery, which is left anterior descending artery. It originates posterior to the pulmonary trunk and can be termed retro pulmonary segment, and divided along its course into three segments. A proximal, which is from the origin of the left anterior descending artery until the first branch of septal perforator. The middle, it is from the first branch of septal perforator until the end, until the last branch of diagonal, and distal from the last branch of diagonal until the end of left anterior descending artery. The main branches of LAD include diagonal arteries, septal perforator artery, and right ventricular branch. The right ventricular branch is not always presented, but if it is presented, can be originate from the left anterior descending artery. You should consider and keep it in your mind that there is anatomical variation of diagonal branch, and this picture showing the morphological variants of diagonal branch of LAD. And this is coronary angiogram showing left anterior descending artery and circumflex artery. The question is here rising that how can I differentiate between the diagonal and septal perforator in regard to coronary angio? Can anyone answer?
I think the one directed downward are the septal perforators. The one going horizontal are the diagonal.
Yes. This is the main difference, that septal perforator is perpendicular to the heart, while horizontally it's the diagonal. Now we'll talk about the second branch of main stem of left coronary artery, is circumflex coronary artery. It's passed just inferior to the left atrial appendage and entering left anterior segment of the coronary sinus before it gives its branches. The point of termination of circumflex artery is at crux. We'll talk about this point later on. The main branches of circumflex include obtuse marginal arteries, left atrial branches, and SA nodal artery. It's found can be originate from circumflex and 45%. AV nodal artery, it's originated from circumflex and 15%, and PDA can be presented in 10%. Now we finish talking about the left system. Now we'll talk about the right system. The right coronary artery is the initial part of the right coronary artery is behind pulmonary trunk, and the space between right atrium and right coronary sinus and pulmonary trunk. as we can see in this picture, this is the pulmonary trunk. This is the origin of the right coronary artery, and this is the main branches of the right coronary artery. It's originate behind the pulmonary trunk. The right coronary artery is the main branches of this artery, SA node artery, which is presented in 55% population, infundibular or conus branches, acute marginal artery branches, and anterior right ventricular branches. AV nodal artery and BDA and posterior left ventricular artery. This picture shows the different branches of right coronary arteries. How can we determine the dominance of coronary arteries? By looking to the crux. This area is in the posterior wall of the heart is where the coronary sulcus and the posterior interventricular sulcus meet. So by looking to this area, if we look to the artery there, the BDA, if it is originate from the right side, it's right dominant. If it is originate from the left side, it's left dominant. If it is originate from both of them, we can call it as co-dominant. This picture shows the right dominant origin of the BDA, and this is the left dominant of BDA. In regard of percentage, in 80%, in 85% of population, it's right dominant, which is BDA originates from the right coronary artery. 10% is left dominant, and 5% is co-dominant. We finished talking about coronary arteries. Before we move to talk about the coronary veins, any questions in regard of coronary arteries?
Can I add something, Muhannad?
تفضل.
On the left system, sometimes there is a branch called the ramus intermedius. It comes from the bifurcation between the LAD and the circumflex. Sometimes it can be mistaken as a diagonal. If it comes from the bifurcation, it's a ramus intermedius.
I think there is a picture. Faisal, you mean this one?
Yes, Muhammad. If you mentioned it, sorry, maybe I did not pay attention.
No, I didn't mention it. Okay. Now move to talk about the coronary veins. It's divided into three system: coronary sinus, the anterior right ventricular veins, and the Bayesian vein. The largest system, which is collectively collects a major amount of venous blood from the left ventricle and end with the coronary sinus, open to the right atrium. The second system of the cardiac veins is gather venous blood from the right two-thirds of the right ventricle and end in the right atrium. The third system, which is the Bayesian vein, comprise small veins that drain different portions of the right atrium and ventricle and empty directly to individually to these chambers. And if we any comment?
Mute your mic, يا فراس.
we continue. Tributaries of coronary sinus, it's anterior interventricular vein, a great cardiac vein, and inferior or middle small cardiac veins. The transition point between the great cardiac vein and before it's come to continue as coronary sinus, it's identified by two morphological structure. Can anyone know which is the two morphological structure that consider the transition between the coronary sinus and the great cardiac veins? The transition point between them is identified by two morphological structure, which is the valve of the Baseus and oblique vein of Marshall. This is considered the point that transition between the great cardiac veins and coronary sinus. There is a surgical correlation in regard of coronary veins, that retrograde cardioplegia provide protection to the left ventricular muscle and incomplete protection to the right ventricle. Thus, the veins of the right ventricle do not communicate with the coronary sinus. So, and the cardioplegia not reach the right half of the heart, and this may be related to the various venous anatomical of the heart. This is a regard of the coronary sinus. Now we'll talk about the great vessels. We'll talk about the aorta and pulmonary trunk specifically. We'll start about talking about the aorta. We'll have an overview about the aorta. Then we'll talk about each segment of the aorta separately. Aorta can be divided into 4 sections: ascending aorta, aortic arch, thoracic or descending aorta, and abdominal aorta. It terminates at the level of L4 by bifurcation to left and right common iliac arteries. And we should keep in mind that aorta can be divided into 12 zones that help with endovascular and for the landing, consider for the landing zone. Now we'll talk about specifically about each segment of the aorta. We'll start with ascending aorta. It arises from the aortic orifice from the left ventricle and ascend to become aortic arch. It's usually 5 centimeter long and travel with the pulmonary trunk and pericardial sheath. This picture showing the ascending aorta and in relation to the pulmonary trunk and pericardial sheath. Aortic arch begin at the level of second sternocostal joint, and its course goes superiorly, posteriorly, and to the left before moving inferiorly. And the main branches of aortic arch give 3 main branches, which brachiocephalic trunk, left common carotid artery, and left subclavian artery. And also we should keep in mind there is anatomical variation in regard of the origin of these branches in the aortic arch. And this picture showing the different morphology of the arising of the branches of an aortic arch. Descending aorta span from L4 to from T4 to T12 and begin on the to the left vertebral column, but as it is descent, it's becoming in the midline of vertebral column. And the descending aorta, it's leave the thoracic via aortic hiatus at the in the diaphragm at T12, and this is the picture showing aortic hiatus. The branches of descending aorta in descending way, bronchial arteries, mediastinal arteries, esophageal arteries, and pericardial arteries, superior phrenic arteries, and intercostal and subcostal arteries. Abdominal aorta, it's begin at the level of T12 and approximately it's 13 centimeter long, and end at L4 vertebra by giving to terminal branches, right and left common iliac arteries. In regard of pulmonary trunk, it's begin at sternal border of the left third costal cartilage. It's 5 centimeter long, and as it is originally, it course posteriorly and superior to the left, and posterior to the aorta and below the aortic arch. It gives to two branches, the right and left main pulmonary arteries, and this is and this branch is identified anatomically at the level of the carina, at the level of T5 and T6. Pulmonary trunk relation. Anteriorly, you will find sternal end of the left second intercostal space and left lung and pleura. Posteriorly, you will find left coronary arteries, ascending aorta, and transverse sinus of pericardium. On the right, you will find ascending aorta, origin of the right coronary arteries, and right auricles. On the left, you will find left coronary arteries and left auricles. This is the end. Any question?
مهند معلش could you repeat البوينت اللي عن المارك اللي between coronary sinus وال cardiac veins.
You mean this ayat?
Yes.
This is the great cardiac veins, and this is the coronary sinus. The transition point between them, this point, is identified by two morphological structure. One is the valve of the basin, and the second is oblique vein of Marshall, this one. This is considered the two morphological structure that the transition point between the great cardiac veins and coronary sinus.
Tamam, thanks.
What's the significance of that?
Maybe, for example, if we are giving the retrograde cardioplegia, like Mohammed, what he mentioned after the slide, maybe it's for example, something that can help in this issue.
So how far do you go with the tip of the retrograde cardioplegia inside the coronary sinus? Ayat,
I'm not sure. I don't know.
can you go back a couple of slides, please? Okay. No.
This one?
No. Go back.
Or this?
Go forward. Okay. Stop here, please. So where is the orifice? Where is the orifice of the coronary sinus?
They are located in the interventricular groove. This is
Show
where
me.
we see them.
I want to see it here on this diagram, on this angio.
So it will be like, I will draw Muhannad, huh? It
Okay.
will be like here, yani, behind this, in the interventricular groove itself.
Big circle. Can you be more specific, please?
Would it be at the junction between the great cardiac vein and the and the middle? Sorry, the great cardiac vein, like on the left side in this image from the great cardiac vein, toward the right side of the heart, at that corner.
Okay, let's ask one of the seniors, please. Murtada. Luay.
Yes.
Can you locate the entrance of the coronary sinus, the orifice?
كيف نرسم يا آيات؟
في ما أدري، أنا على جوالي في قلم في تحت على اليسار.
I could not find it, but I.
Okay, it's all right. What's the significance? What's the significance of knowing where the orifice is in relation to the branches? Yeah, Luay.
I would say, as Ayat mentioned, maybe during the retrograde cardioplegia, you want to avoid any injury to these veins.
Well, you'd like to avoid any injury to the veins or to the coronary sinus itself. But more significant than this, there's an important issue. يمكن one of the seniors can ask us, can answer this. مين عندكم senior? Who's this?
هيثم.
هيثم.
You don't want
أنا قلت ما أبغى أحرجك عندك امتحان بعد يومين.
You don't want to exceed the
Okay.
middle cardiac vein, so you to have some protection for the right ventricle.
So where does the middle cardiac vein drain?
In the RV.
The middle cardiac vein connection, where is that? It drains from the RV into
into the pathway to the coronary sinus.
Okay, into the coronary sinus. Where in the coronary sinus?
Just before, when you insert the cannula for the coronary sinus, if you advance it a little bit, you will close that. You will be distal to the middle cardiac vein.
So it's almost at the orifice. It can be a little bit short distance, and that can be compromised if you give cardioplegia. And
Yes.
That's why retrograde cardioplegia alone may not be sufficient to protect the heart. Did you
Yes.
get that, Muhannad? Muhannad?
Yes. Yes.
Did you get that?
Yes.
Ayat?
والله not really.
Okay, Faisal?
Actually, no, yeah, doctor.
Okay, so please show us the middle cardiac vein on the diagram, Muhannad. On the angio.
This one.
Yes.
Okay, and it connects right to the coronary sinus. So where's the orifice of the coronary sinus, Muhannad?
There.
No.
بالضبط. يعني okay, a minute or two, maybe a half a centimeter away from there, but that's the area. It's not the left, extreme left, يا فيصل.
Okay,
Faisal.
Doctor. Yes, I understand, Doctor, now.
Now is it obvious?
Yes, it's if I
Okay,
can
yeah, نرجع
just
لآيات.
ma-
آيات, is it obvious?
Yeah, دكتور.
Okay, all right, thank you very much.
Thank you مهند يعطيك العافية.
Go Muhammad, please, one slide forward.
This one?
Yeah, so this vein of Marshall also had its significant for arrhythmia surgery.
How is that, Dr. Haytham?
Actually, when you do the arrhythmia surgery, there is some paper talking about ablation of this vein as well, because it's there is a lot of conduction system around it. But there is a significant in arrhythmia surgery as well. One of the lesions that you do also toward the coronary sinus, but you need to be sure not to injure it as well, of course.
Okay.
But that one, there is ongoing trial, so just we will see the result of that one.
Thank you, Mohammed.
Okay, anyone has any comment or question? Okay, thank you, Mohammed. Thank you, everyone.